Welcome to the Brain Health Hookup. I'm Laurel Myers Hurst, your resident groovologist, and I believe that better mental health needs to be fun. Here we talk about mental wellness, we explore the physical, emotional, and relational needs we have as humans with the science and practices that help our mental health to flourish. Plus, we dive into my signature method, groove therapy, that engages folks in groove-based music making to lift mood and lower inflammation and pain. I'm so glad you're here. So let's hit it. Well.
Well, truly a deep subject.
Today I'm going to talk about one of the things that may be the most controversial of all things I will talk about. I might eat my words later, but we're going to talk about the word bipolar. Few words strike the same kind of terror in the hearts of families and clients as the word bipolar. Maybe only outdone by schizophrenia or psychosis. Bipolar, though, has a specific connotation of an enduring, cycling, painful, inescapable disorder that often leads to disability. And when we hear the word bipolar, there's a kind of fear and stigma surrounding it. There are a couple of reasons for this. For one reason, mania, the most significant and defining feature of bipolar disorder, is very disruptive. When someone experiences mania, they may act completely outside of their typical values, their typical habits, and they may do things that once the period of mania is ended, they look back and realize there's been a huge amount of damage done relationally, financially, physically. So mania has many after effects that are very painful for the person who experiences those periods. Some people with bipolar disease are very well controlled with medication, and many are not. So the word bipolar has that stigma of a very severe impact of unwellness. The other thing that strikes me as specific to bipolar disorders is the types of medication we used to give to people with bipolar disorder almost exclusively. Many of those medications either damage kidneys or damage liver. And because those are essential organs to life, bipolar disorder often had that connotation of a shortened or foreshortened future. That if you have a bipolar disorder, you may not live long, and that life will be very difficult, not just for the person with the disorder, but family members who try to support, try to keep safe the client in those times of mania. This has been even further confounded by the addition to the Diagnostic and Statistical Manual of Diagnoses in 1994 of the BPAD-2, Bipolar Affective Disorder 2 diagnosis. That's not to be confused with BPD, which is borderline personality disorder, and I could go on that a different tangent, but BPAD-2 is significantly different from BPAD-1, Bipolar Affective Disorder 1, because Bipolar Affective Disorder 1 includes mania, and Bipolar Affective Disorder 2 does not. That confuses patients very much because we assume the word bipolar means mania, but mania is only present in bipolar affective disorder 1. In truth, if you ever had a case of true mania, you cannot have a bipolar affective disorder 2 diagnosis. So they're quite distinct. What is bipolar affective disorder 2 like? Roger McIntyre has done a lot of work in advocacy, not just with other psychiatrists and prescribing and diagnosing providers, but with the affected community, people who have lived experience with this disorder. Roger McIntyre points to features including depression and then atypical features of depression, affective features. So the way we appear in the world, the way we act, the way we feel. People with BP82 have depression with affective features like anxiety, attention problems, agitation, anger, and sometimes problems with sleep. Again, I said this episode might be controversial, and here's why. I would say many people who have been treated for years or even decades for depression and find that their depression is very deep, unresolved by medication, and they also have anxiety, attention problems, agitation, anger, and sometimes problem with sleep, actually have depression with affective features or BP82, and they're not on the right psychotherapeutic track and or medication track with the right support for brain health to see their symptoms go into remission. I know that's controversial to say among like people who are seeking care, but as a provider, I'd rather proverbially take the bull by the horns and see people come into remission than dance around the topic about what's actually going on. Again, if people have very deep depression with affective features of anxiety, attention problems, agitation, anger, and sometimes sleep disturbances, they very likely have BP82, not what we say unipolar depression. So they have periods of depression, but also periods of irritability or being amped up and then back down into depression. I recently listened to a widely distributed scientific talk by Dr. Tadafumi Kato of Juntendo University in Japan. This is one of the best explanations of what's going on in BP82 or depression with affective features that I've ever heard. It made so much sense to me and how I see my patients moving in the world. Dr. Kato said that the mechanism of action behind BP82 is rooted in nerve irritability in a specific place that we can see in functional MRI. I've mentioned in other episodes how functional MRI is changing how we understand mood disorders of all kinds. This is one great example. So there's a part of your brain called the lateral hypothalamus. The hypothalamus, think about it as the command center for your autonomic nervous system. You maybe have heard of the autonomic nervous system. Remember, your sympathetic nervous system is what comes into action when you're in fight or flight mode. You're getting amped up. The autonomic nervous system is what should be going on in the background all the time to keep your ship sailing the sea, right? Your hormone release, your body temperature, your appetite, your sleep-wake cycles, some emotional responses to stress, including actually the beginning of infatuation or feelings of love, thirst cues, and generally running the ship that's your body through your nerve connections. You might have, again, heard this system called the autonomic nervous system. The hypothalamus is the command center for the autonomic nervous system. Well, in BP82, we can see in the functional MRI that the lateral, the side of the hypothalamus is irritable. Interestingly, that part of the brain has projections or nerve connections with two different kind of competing areas. One area is the reward center of the brain, and the other is the fight-flight center of the brain. Usually they fire at different times. In typical people, you'll either feel like, oh, I like that, or, I don't like that, get away. But you don't feel both at the same time. Interestingly enough, in people with BP82 or depression with affective features, from the lateral hypothalamus, the side of their autonomic nervous system command center, these projections for both reward and fight flight fire at the same time. I've heard parents with teens who could be described as having BP82 as being extremely irritable, very agitated, mouthy, demeaning, disrespectful, explosive. And when those episodes are done, they will come to the parent in tears saying, I don't know why I'm like this. I can't stop it. I have no idea why I would do that. I don't want to, but in the moment, I cannot stop. You can see how if the brain connections are moving toward reward and fight flight at the same time, how that might be happening. But why is it happening? Dr. Kato explained that nerves become irritable when they have too much calcium inside of their membranes. And this is the case we see with cells that have this trait of bipolar affective disorder. In animal models, they showed that the calcium control, keeping too much calcium inside the cell, leading to irritability, fired these two competing networks simultaneously when they would normally fire at different times. So amazing work in trying to understand what's happening in human beings, again, through animal models. We see plenty of other clues that dysregulation of the autonomic nervous system is involved in both mania and depression with affective features, because the lateral hypothalamus includes interpreting our food cues, controlling sleep and wake cycles, managing energy throughout the day, the perception of pain, the control of inflammation, encoding memories about things that felt rewarding, like thirst cues, like we mentioned before, and also sex drive. In true mania, most of these things go out the window. You might see in an episode of full mania that people either gorge themselves on food or don't eat at all. They don't understand their natural food cues. They might take off walking down the highway with no shoes on in the middle of the winter and think that's a great idea. They might also act uncharacteristically related to their sex drive in ways that would completely violate their values at other times. But you can see that dysregulation of the autonomic nervous system as the basis for that. Again, true mania is bipolar affective disorder 1. In cases of bipolar affective disorder 2, we can't have ever had a case of true mania where we're acting contrary to our values in a way that we're a danger to ourselves or others, probably needing hospitalization or direct one-to-one supervision. So again, bipolar affective disorder 2 may have irritability and also those features of anxiety, attention, anger, agitation, sleep problems, a very much dialed down form of mania that is truly not mania at all. I honestly would prefer very much that bipolar affective disorder 2 did not have that name. The whole bipolar word in BP82 leads people to think that mania is involved. But what we see is much more depression, longer periods of depression, deeper depression, and outrageous amount of anxiety, attention problems, often agitation and anger, and very, very frequently sleep problems, sometimes that start from childhood. What would help, in my opinion? Better understanding of the diagnosis in general. When we understand that bipolar is not a word to be feared, that mania does have its challenges, but BP82 is not mania per se. If more people could receive a BPAD2 diagnosis without stigma, we could employ psychotherapy, anti-inflammatory strategies, nutritional strategies, and medication strategies that would work much better for that condition than treating year after year, decade after decade for depression ineffectively. You might remember that in episode 8, we talked about the criteria for a failed medication trial. Those should be taken seriously. If a person reports depression to their provider and yet they fail legitimate medication trial after medication trial, then a different diagnosis is probably the way to move forward. The proof, I've said before, the proof of the diagnosis is in the movement toward remission. If people don't move toward remission when they're receiving a treatment, either the treatment is wrong or the diagnosis is wrong. So I still feel very strongly that understanding of the diagnosis and very structured medication trials with very clear parameters would be very helpful for shortening the amount of suffering people do before they come to remission. Also, people need much better support for managing really deeply felt emotions and emotions in general. Emotions are endogenous motion. They are felt inside and they're intended to move us forward. When we feel things, we have the opportunity to act, to take that energy to do something new. But deeply felt emotions are often either just dispelled without beneficial activity, or they're tamped down. Very few times are people taught to take deeply felt emotions, use that energy to make the changes that they want. Even anxiety and sadness can be, you might say, sublimated, right? We are taking that energy and doing something with it into the change that people want to make. We also need better baseline assessments for things like sleep, like we talked about in episode 9, nutrition, which we'll be talking about much more in the future, inflammation, and past or current woundedness or trauma. There's another amazing scientific talk out there by Barton Evans about the intertwined nature of bipolar affective disorder 1 and 2 and trauma or woundedness. I find that in most cases where symptoms of mania or hypomania, BPAD2, appear, there's also in the chronological history a very distinct woundedness. And that woundedness, I rarely say the word should, but I'm going to say it here. That woundedness should not be discounted by other people. I've heard parents say, my child's symptoms appeared when I divorced my husband, but that person wasn't the child's father, so it really shouldn't be that big of a deal. No outsider can interpret for you how wounded you are by any one thing. And hearing that you should not feel upset or be wounded over something does not change the status of the wound. The proper reaction is to acknowledge pain and to stand by, stand with, and stand in as somebody makes their progress toward healing. I think that a better assessment and a better response to woundedness would be key to helping more people who could be diagnosed with bipolar affective disorder too. The way forward is definitely to focus on brain biology, effective psychotherapy, and then medication as needed for the symptoms. If you or somebody you care about has been affected by depression with affective features, I hope that you will take this information, bring it back to your provider, take a second look at inflammation, nutrition, woundedness, and then the basics of sleep and movement, and also, as it's needed, the proper medication inside the correct parameters for correctly handled trials until remission is found. Remission is definitely possible, and every single person deserves it. Thank you for tuning into this episode of the Brain Health Hookup. I hope this episode radiates with the conviction that generating mental wellness needs to be fun and safe. We want you to find your power and understand your innate design to flourish in everything you do. And we hope that inspires you to come back and listen for more. I'd love for you to leave a review of this podcast, as it helps the show grow to reach more people who need to make mental wellness fun. You can find the leave a review button, as well as all the YouTube visuals, bonuses, and ways we can help to support you on our website, podcast.grooveforhealth.com. I appreciate you more than words can say. See you next time, and remember, together we have everything we need.